Moving on to the lower extremity with the sciatic nerve, piriformis syndrome is a common entrapment site of the sciatic nerve proper. Because the sciatic nerve is a peripheral nerve, it can be entrapped by the piriformis as the sciatic nerve is exiting the pelvic basin. Etiologies can be direct or indirect trauma to the gluteal or the sacroiliac region. Contracture of the hip causing pelvic obliquity can cause this. We tend to see this more in women than men, but that could be a reporting issue and not necessarily a genetic predisposition. There's spasm or inflammation to the piriformis muscle, putting direct compression over the sciatic nerve, very similar to that of what we see with pronator teres muscle. Buttock pain is present, but lower back pain will not be seen with piriformis syndrome proper unless the low back pain is a secondary involvement with the piriformis syndrome, meaning there is some lumbar compensation secondary to the altered gait pattern because of piriformis syndrome. This slide is showing the anatomical relationships of the sciatic nerve. Because the sciatic nerve is comprised of the common peroneal as well as the tibial nerve, there are small variations that do exist in which these two studies have shown the difference on how the nerve can split the muscle, dive between the muscle, or be surrounded around the muscle. But the majority of the piriformis to sciatic nerve relationships is that of a normal entity, as identified as 88 and 85% of the studies. This just needs to be something we need to think about, that there may be an anatomical variant. Though with anatomical variants, the symptomatology for piriformis syndrome would have been brought on earlier in life. We tend not to see this coming in the 40s or 50s as a first presentation. The deep peroneal nerve can get entrapped at the knee, more appropriately near the fibular head. It is common entrapment sites as the extensor retinaculum and distal to the neck of the fibula, and this can produce foot drop. Just as we saw radial nerve entrapments can cause wrist drop, in the lower extremity, deep peroneal nerve entrapments can cause foot drop. This needs to be differentiated from an L5 radiculopathy. Though the sensory pattern with an L5 radiculopathy and deep peroneal entrapment will be different. So we always have to match the sensory findings, the motor findings, and or any appropriate reflex findings to determine, is this coming from nerve root or is this coming from peripheral nerve? And as noted on this slide, the sensory pattern for deep peroneal nerve is between the first and second toes. This slide helps to identify the sensory innervation of the lower extremity. Please review the aspect of this slide to get a better understanding of the sensory involvement. Tarsal tunnel syndrome is entrapment of the tibial nerve within the tarsal tunnel. Remembering, as the tibial nerve descends down the leg, it passes underneath the tarsal tunnel and then splits into the medial and lateral plantar nerves respectively. Etiology can be post-traumatic, neoplastic, inflammatory. We tend to also see this from foot deformity and poor shoe use. Physical exam reveals a positive Tinel's foot sign. There'll be pain with passive dorsiflexion or inversion of the foot. There tends to be tenderness over the tunnel itself, and there'll be weakness of the foot intrinsic muscles innervated by the tibial nerve, though the neurological exam with tarsal tunnel syndrome is normal.